Good evening, everyone. Today, we are fortunate to have with us an esteemed panel of experts who bring diverse perspectives on how polygenic risk scores are transforming health. Together, they will delve into the science behind polygenic risk scores, explore their current and potential applications, and discuss the opportunities and challenges that lie ahead. Please join me in welcoming our panelists, and without any further ado, let's begin this important conversation. So first, I would like to start with Paul. So could you briefly explain to our audience the concept of PRS and its utility, please?
Yes, certainly. So polygenic risk scoring is effectively looking at the risk profile of an individual across a number of different genetic markers in the genome that individually may not prefer a high level of risk, but actually in aggregation can indicate a risk score for that individual. And so the way I've seen that manifest itself in practice is that those scores, so if we were to talk about a monogenic disorder, a disease that was linked to a single gene, there are systems and processes to address that in a healthcare system. And so the polygenic risk nature of these is sometimes more contentious. I think we may talk about the implications of this in terms of practical application in a health system. But where I've seen it being used, and you could argue this is a wise application of this, is when the equivalent risk from a polygenic risk score is the equivalent of a monogenic risk score, then the health system seems to be ready to act on that. And so I've heard the idea that 3 standard deviations from the mean for a polygenic risk score would be indicative of something akin to a monogenic disorder, and therefore it is something that we could start to act on. So there's those kind of principles that would be relevant to kind of managing this predictive element that is being introduced into health systems as a result of the genomic insight that's coming from the world at the moment.
Great, thank you. So with this background information on what are polygenic risk scores, so I would like to ask Dr. Stephan, could you please shed some light on the global implementation of these polygenic risk scores?
Thank you for the question. A lot of the original polygenic risk scores were developed on patients of American or European ancestry. And they have shown efficacy in helping identify patients who are at increased risk for certain medical conditions. In our case, it's higher risk for developing cancer, but in other settings, there are other diseases that also may be predicted by a polygenic risk score. What's been learned since the initial development of polygenic risk scores is that a polygenic risk score in an American population may not apply to other populations. So a lot of work is now going on into studying existing polygenic risk scores in different populations and or developing new polygenic risk scores for new populations. And that's what I think makes what we currently have so exciting because we now have the resources to begin to unravel polygenic risk scores in the patients that we serve here because of the Emirati Genome Project.
Yeah, thank you. So having this knowledge on how well we can implement polygenic risk scores globally and what is the importance of having this population involvement, I would like to ask Dr. Javier. So in your opinion, how important it is to have population-specific data to launch successful PRS program?
Actually, I think that will be one outcome of VGP because, let me unpack my answer. So I think the panelists will agree that what we need is PRS models that work, right? There's no need to tailor them to a specific population just per se. So as Dr. Grobmyer was saying, those were developed in Western or Caucasian populations, and that has some biases, and there's been some concerns about them not applying to Africans and Arabs. So what we need is take those models, check for the ones that perform well, check if they have been validated in other ancestries, that will be a good check, and then try it in the Emirati population. And if those fail, or even if you want to enhance them even more, with EGP we have the great opportunity that we can develop our own models by doing the same process that others have done to develop those models. So the point I'm trying to make is let's not rush to go first and make specific models. Let's try the existing ones. For breast cancer, there are wonderful models that are very well used. They have been validated in multiple ancestries. Truth, they still need to be validated in Arab or Emirati ancestries. But let's take those, and that's actually the direction we are taking with Dr. Han and Dr. Grobmyer. Try them in the Emirati population, check if they transfer to the Emirati population, and if together with the EGP we can make them better or not. And I think that's the key question to go to the ultimate goal, which is models that they can apply into the clinic.
Okay, thank you. So building on this kind of information, like how we can utilize the existing models and then extend to the local Emirati population. So I would like to ask Dr. Fawad, as the medical director of the hereditary high-risk group, what are your thoughts on PRS being implemented as a risk stratification tool in your clinic?
It's a great question. So as you know, in the hereditary high-risk clinic, what we do is we focus on identifying which population, out of the population, who's at increased risk of developing cancers. And we would bring them to our hereditary high-risk clinic. We would do a risk stratification before we put them on precision prevention programs. And the way we do at the moment, traditionally, is that we use, based on the family history, we would do a risk estimation using the traditional risk models, such as Tyrer-Cuzick or CAN-RISK. And the other set of population would be the ones who would have germline genetic testing and who would turn out to be positive for pathogenic mutations. Based on the risk given by that specific gene, we would put them on the precision prevention programs. And the four prevention pillars are enhanced screening, lifestyle modifications, preventive medication, preventive surgery. But where PRS is going to be playing a very powerful role is, and these are studies large studies going back to 2015 onwards, where the patients who have family histories, we'll be able to refine the risk further with the help of PRS. And I'm specifically talking about the breast cancer here. Studies also show that patients who have had cancer gene mutations, so this was a big study published in 2020 by Gallagher and team on 153,000 women, mostly European ancestry, which showed that PRS was able to further stratify the risk of patients who had cancer genes. More relevant for moderately penetrant genes. But the third set of population, which at the moment we are not tapping into, are the ones who do not have a family history, who do not turn positive for any pathogenic mutations. But they make the majority of the population. So we know that up to 70% of the breast cancers are sporadic. PRS can also play a very important role there and will be able to stratify the risk of those women who do not have family history, no genetic mutation. So I think with the help of PRS, once validated, it will really help in substratifying the risk of the entire population, and then be able to offer them, in real terms, the personalized precision prevention programs. I mean, just a quick example of, a woman who's 50 years old, has breast cancer, and if her 3 daughters, once they go, into 30s, if we do their risk estimation using the traditional risk models, all 3 will be at increased risk. But with the help of PRS, again, once validated, we'll be able to understand who's very high risk, who's going to be at 80% lifetime risk, who will then be a good candidate for surgical prevention, medical prevention, and who's at just 20% low risk and does not need all those surgical preventions and those drastic prevention measures and just needs enhanced screening. So I think in the future, this is going to be playing a huge role.
Yeah, that's really wonderful to know, Dr. Fawad. So PRS is not just being implemented, at the population level to adapt the models that we have, and it can also be used for the patient stratification. And what is even more interesting for me to know is within you stratify the patients at high risk, you are able to sub-stratify the patients who are at the very high risk and who are at the lower risk so that we can utilize our resources effectively and we don't have to perform unnecessary surgeries on people at lower risk, right? So maybe some screening programs might be enough for lower risk, but for higher risk women, maybe they need surgeries like as a preventive care, as you mentioned. Thank you so much. And it is getting really interesting, so on. So the next question to Paul. What do you think are the challenges in implementing PRS, and what might be the main reason behind its slow adoption here?
So I think one of the things to flag, and it depends which area of medicine you're talking about, because there's a potential here for PRS to have relevance across multiple different areas of medicine, is the healthcare system ready to accommodate this early detection, potentially preventative type of agenda in the mix? So the implications of uncovering more people in a system and the preparedness of the health system to accommodate that and to make sure the care pathways are in place and the professionals are there to support the process of patient care. I've heard it articulated to me as I've explored this domain that we are very aware of risk profiles of individuals without doing polygenic risk scoring. And in some cases, health systems around the world are struggling to accommodate even the risk profiles we have now. So this add another dimension to the mix that increases the risk even more is the system is already struggling to cope with what we have on the table now. But at the same time, I think there is this extra dimension. Polygenic risk score can identify those at super high risk, and actually you can see there's a huge benefit, and if you can demonstrate that impact, that you can change someone's life, you can detect early. I think there's a really interesting dynamic there that ought to be explored. So it's about the preparedness of the system to accommodate the implications of what you are uncovering that didn't exist in the past. And you can understand, it's at the highest levels, it's this shift from healthcare to health that we've touched on many, many times today. And it's about how you make sure the system can accommodate that.
Yeah, great. Thank you so much. So since we have a lot of data sets here in the UAE, so my next question is to Dr. Stefan. Given the lot of data sets, for example, like Malafi or Emirati Genome Program, how will they transform cancer care in UAE, in your opinion?
There are many ways. Let me focus as it relates to PRS. One of the things we've observed and published on since I moved here 5 years ago is, and I'll give one specific example, in breast cancer, a quarter of the patients we see are under the age of 40. A quarter of the patients we see here are under the age of 40. There's no standard screening for women before the age of 40. So we desperately need ways to identify people who are at higher risk, because we can't do mammograms on every 30-year-old woman. It's not a reasonable public health strategy. But there may be blood-based assays, although they have cost. There may be other types of screening we can do, but we want to apply these new and sometimes more expensive tests on patients most likely to develop disease. So I'll give you another example. There's some interest in developing blood-based screening tests or detection tests for certain types of cancer. And for certain cancers where there's a very low incidence of the cancer in the population, it may not be the most cost-effective thing to do an expensive blood-based test looking for a rare cancer. But if we can take a family history and embellish it with a PRS, which identifies, in addition to clinical factors, somebody at significantly elevated risk, then it may be cost-effective to start doing blood-based screening in those patients. And so I think there's a benefit to patients and also, in the end, a health economic benefit to this, because we really need this in the clinic so we can apply the right screening to the right patient and ultimately reduce the incidence and burden of cancer.
Thank you very much. So since we are already discussing on the utility of the existing data like Emirati Genome Program and how we can utilize the information, so I would like to ask Dr. Javier. So since we have this unique program in the UAE, the EGP, so where an entire population will be sequenced and this allows visibility of familial structures, so how does this impact studying PRS scores?
Yeah, I think that normally people look at PRS either at the individual level, saying, okay, I can predict the risk of that person specifically, or maybe more at the population level, where maybe you compare Arabs versus some European countries, so you can take maybe public health decisions. But I think something unique to the EGP is that you can define the families, and then you can map the PRS on that. And I think you can use that at least in two ways. First of all, maybe that familial information can be fed into the model, so that maybe we have more predictive models if we combine or ensemble the PRS that you could get across your relatives, and the other way around. So now maybe instead of only looking at your individual PRS, maybe we can have an aggregated PRS for your family, so that we can identify families that may be overall a higher risk than the baseline population, so that we can consult them as a whole, as a nucleus, which I believe is an important component of the Emirati society. I wanted to comment on something that Paul mentioned on the challenges. One of the challenges is that also something that he mentioned nowadays, like the PRS are expressed as on which percentile you are in terms of risk. And I think that's one challenge is going to be how to translate that into doctors, because at the end of the day, like being on the top 5 percentile, it's not a probability, it's not a lifetime risk or a 10 years risk. So we need to work on how this is going to be expressed to doctors and patients. And also this being on the top 5 percentile is relative your reference, all right? So if now we do a first pilot on 250,000, and then maybe we expand it to 500,000 and eventually to 1 million, or maybe over the years we keep expanding, like one patient is always going to be on the top 95% or on the top 5, or it's going to be fall off behind. So I think these are things that by pioneering in PRS, we will have to think about, and it's going to be one of the challenges in terms of implementation in the clinic.
Thank you so much. So I would like to come back to this high-risk stratification, if you don't mind, Dr. Fawad. So how will the addition of PRS complement the tools that you already have in your clinic about the high-risk clinic to use the genomic screening at population scale?
So we've already established that PRS has a very important role in breast cancer risk stratification in all the 3 areas. So the population who have cancer, pathogenic mutations, the population who have strong family history, suggestive of hereditary cancer, and then the ones who do not have either of them. I think if we imagine a situation where we have the entire Emirati population's genomic information there, and once we have validated the PRS, we can apply PRS in all these populations, in all the 3 categories, and be able to identify who is at high risk, place them on the precision personalized prevention programs, and be able to prevent breast cancer. So I think this is going to be where we want to be. I mean, right now we are already we are in the 3rd year of our hereditary high risk program. We have just started. We have over 800 high risk established patients on preventive programs. We've just started taking on the EGP population as well. I think we are, this is going to be a perfect scenario when we get there and we're able to utilize the EGP data combined with Malafi. So that's the other strength we have, because we'll be able to, through EGP and Malafi, we'll be able to also identify who has the family history. So all that clinical information will also come into play. I think that would be where we want to be eventually. And just to piggyback on what Javi and Paul were saying, I think from here to the clinical application of PRS, one of the big areas to work on would be to standardize the PRS model. So at the moment, we have multiple PRS models, 2 pretty popular ones. One is the 313 European PRS, which we are going to be probably using in our research study. And then we have the MAPRS from the US. But how do we have that PRS, which is going to be truly multi-ancestry? Because we know our Marathi population has been underrepresented in the other PRS. So I think this is where we are working, and our research is going to really pave the path towards clinical implementation, I believe.
Thank you so much. So we have a couple of minutes. So if any questions from the audience? Yeah. Can somebody please?
Thank you. Not sure who to direct this question to specifically, but if I think about PRS in a European or a US context, it struggled to really adopt into mainstream workflows, into mainstream clinical care, primarily because I think just a general payer reluctance to pay for asymptomatic screening, right? Now, having listened to a number of the sessions over the last few days, it's quite clear that in many aspects of precision medicine, M42 is leading the charge. Is there a view here that if we can fix the ancestry question, there is an evidence generation strategy that will actually lead at some point in the future or the near future to PRS being a reimbursable event in the UAE?
Great question. I'll give you my perspective on that. Our vision, and we talked about this earlier, is to be proactive with our germline genetic testing. Most of the patients we test are going to be negative for BRCA1, PALB2, all these things. And on the back end of that, we incorporate PRS in my field for breast cancer. So it becomes part of the standard of what we do. And if you look really to the future where this information is just being provided, I mean, I know there are ethical issues with that, then it really does become something that's sustainable. And the other thing that I think maybe the reason it hasn't caught on in Europe and other places is they don't have access to 700,000 patients who've already had clinical grade whole genome sequencing. So the incremental cost of providing the information is relatively low because the cost of all the sequencing has been done. So it becomes, from a population healthcare delivery standpoint, a much more valuable approach here than it might be in other places because of the investment that's already been made.
Stephen, I couldn't agree more. I think the other angle, and I'll take your point, Cameron, about the application into health systems, but the other thing I'd just like to add to the mix, and actually came, Cameron, from the discussion we were having yesterday, was this: there is also an interesting angle here from a pharma perspective, from a biotech perspective, where in some cases they are looking for patients very early in the disease progress phase. And so the early detection of patients, it's another interesting aspect to this that I think could facilitate funding, generate more evidence, that could facilitate the wider acceptance of this in multiple spheres. So of course the clinical application is what we're striving for, but from a research pharmaceutical perspective, that's another dimension where there is an interest in many cases for getting access to patients who in the future may be at risk, but an early engagement around that could be an interesting proposition. So there's a whole another field.
Just a couple of words. I think most of the research, as we know, on PRS has been on European ancestry over the last 10 years. So one of the other reasons why it's not being used for clinical implementation at a larger scale, even though in small areas it is being used, so we know some of the labs are reporting moderately penetrant genes at the moment it's being used, is because of the ancestry part, as you very rightly mentioned, because it cannot just be offered to a specific ethnicity and not to the others. And in this particular situation where we have the Emirati EGP, Emirati Genome Program, we will not have that challenge. And our research is also based on the Emirati population. So I think this will not be a challenge. Thanks.
Yeah, another question there. Can you please pass the mic?
I have a very basic question here. I know a lot of factors are involved in estimating a polygenic risk.
Can you please come to the front? Because it's a bit hard to hear you.
Yeah. I see that there are a lot of factors involved in calculating or estimating a polygenic risk score for any specific condition or various conditions. But the set of genes that are involved or that are taken into consideration to calculate a PRS for a particular condition is still not established. So say for example, if it's for hereditary cancer screening, We know there are specific guidelines by NCCN where they very specifically define that these are the set of genes which are to be considered for estimating the risk, hereditary risk. So do you foresee any such guidelines for setting up a standard or fixing up a set of genes for every specific condition? Because if this doesn't come into the picture, at different locations or from different parts of the globe, you tend to see different polygenic risk scores for various conditions. What I mean to say is somebody gets tested in one country, they might have, the result might be shown as a high risk for a particular condition, but the same person, when they get tested at a different location, the classification would vary. And again, it boils down to the same point that Dr. Fawad Khan had mentioned, that we do have a lot of scoring systems in place here. So if the methodology is one aspect which needs to be fixed, I think the guidelines is also one more aspect which needs to be addressed, especially in terms of narrowing down or fixing onto the specific set of genes which are to be considered. Only then there would be consistency in result across the globe for any condition that has been screened.
It was a long question, but I'll try to touch on it. So I think that's the beauty of PRS, that it's in principle agnostic to the set of genes. Actually, PRS comes from agriculture, where what really matters was not understanding the genes that were responsible of high milk production, but what they want is high milk production, right? So in principle, when you develop a PRS model, you don't even select for the genes. Nowadays, we are so privileged that we can do scans of the whole genome, millions of genetic variants that are associated between, if you take breast cancer, healthy versus breast cancer, you have the statistics metrics that Paul described, and then you feed that into a model. Not only we will discard the ones that are not irrelevant at all, but it will try to shrink the model as much as possible so that you have a minimal set of markers, totally agnostic to any preconception of which genes are relevant. So now, it's obviously relevant to discuss those models with clinicians, but in principle, I don't see any need on agreeing on a set of genes for your PRS. What you want, and this goes back to my initial question, is what we need is models that work in not only one population, but on another population. Whether for that you use set of ACMG genes or genes that are yet not known to contribute to the phenotype or disease, I think that PRS will be agnostic to that.
Just to piggyback on what Javier is saying, PRS, although has significance in a number of chronic conditions, chronic diseases like coronary heart disease, studies have shown role in diabetes, but in the cancer world, it's more, the most studies are with its association in the breast cancer risk. And going back to one of the largest studies by Gallagher and et al. On this 153,000 women, showed the importance of PRS in almost all the breast cancer genes. So we know of 13, and out of those, they looked at the 11. And it showed the biggest significance in the moderately penetrant genes, specifically the CHEK2 mutation, where it showed the range from 20% to 80%. So you can again see the impact. And it had, it was actually a very good study to look at as well. So I think we have plenty of studies to show the association and impact of PRS in breast cancer genes specifically. Thanks.
Thank you so much. And please give a big round of applause to all our speakers. Thank you for your attention.